So now we correct the relationship between the teeth and the bone, but the relationship between the two jaws is worsening now. So we have a huge gap here between the upper and lower jaw, 14 millimeters. Then we carry out the orthodontic surgery after preparing the everything for surgery, paralleling the root as well as preparation the orthotomy line for the area for the surgeon, and we need the rigid wire here, which is 1925 stainless steel, and we did some sort of decompensation, leveling and alignment and everything before surgery. Then we carried out the surgery for the patient. I will just show some part of the operation. We carried out the surgery at that time. This is it was like 2011 or 2012, as well as I remember. So here we used to put the correct occlusion inside the theater in a proper way. Before leaving the theater, we have to make sure everything is correct, and we have to take care about the condyle position while doing this procedure. So to avoid relapse, to avoid some sort of idiopathic problem, to avoid some sort of hidden problems, you have to make sure you are in the right surgical procedure by using your surgical splint or whatever. This is progress photo after 2 months after surgery. So this is which we call it post-operative orthodontics or post-surgical orthodontics. You have to carry out some sort of detailing of occlusion. You have to put some sort of elastics. You have to make sure everything is going in the right direction. And here the healing of the surgical procedure and everything is settled now. This is a post-surgical photo for the patient. This is intraoral photos, and this is after surgical as well as orthodontic treatment. And now our occlusion is class 1. Everything is class 1 inside the relationship, canine relationship, molar, a little bit in class 2, which is full unit class 2, which is stable for us. This is pre, and this is post after treatment. This is after treatment. This is her face and her smile before the treatment. And this is her profile before the treatment. This is her profile after the treatment. So the patient was very satisfied at that time. And this is her first day. She's asking me, what are you going to do for me and for my case? And this is her smile after doing surgery. Second patient, in which you have class 2, division 1, 12 millimeter overjet, complete overbite, or which we call it complete debite, vertical problem as well as anterior posterior problem. For this case, we didn't see her lower teeth at all. Her X-ray, class 2, division 1, complete deep bite. We carried out pre-surgical orthodontics, leveling, alignment, and everything. 2 days after orthopedic surgery, you have to tell the patient there is some sort of swelling uh, due to surgical procedure, as well as due to some sort of drugs you're going to use during uh, during surgery. Apologize. Sorry. Due to some sort of swelling sometimes with the patient. For orthopedic surgery, this is a plate and OPG. Have to make sure everything is settled. This is her profile after surgery. And this is her smile before surgery. And this is her front view before after surgery. This is her smile before surgery. This is her smile after surgery. This is her lateral view before surgery, and this is her profile after surgery. This is her teeth after surgery, which we correct the vertical problem in a proper way. So this is the case before surgery, and this is the case after surgery. So whenever you have vertical problems due to skeletal etiological factor, go for some sort of orthodontic surgery. She came to me and she mentioned that I'm very happy at that time. Third case, in which we have two jaw problem. This patient coming with some sort of long face, incompetent lip, class 2 division 1, increase over jet, increase vertical relationship. We have a lot of problem. Posterior, vertical, soft tissue problem, and everything. This is a case before, anterior open bites, class 2 division 1, increase over jet, missing some teeth. So you have to do something for her. We start our treatment first with orthodontic therapy. She came to me after a while, and there is some sort of uncontrolled hygiene. And it took her more than me. She brought her for hygiene later on. We create some sort of surgical straightened line. Have to prepare something for this before surgery. And we carried out, which we call it VTO or visual treatment objective for the patient, in which we are going to carry some sort of analysis for the psychometric to do some sort of movement before surgery and to imagine what is going on after surgery or what is the result after that. So we have to go for which we call it VTO analysis first. And this is part from the surgical procedure. For this case, we carry out double jaw surgery. So, wherever, wherever, the guidelines for us, the guidelines for us. So we have to take over here. This is our seat. This. So, Professor, uh, one of my distinguished professors who teach me a lot, as well as we carried out a lot of operation together, as well as his company, Clayman, another professor in surgery. This is the maxillary surgery. This is the mandibular surgery for this case. This is 6 months after surgery. After surgery, settling of occlusion with intermaxillary elastic is very important. Minimally, it should be for 3 months. And this is the patient 7 months after surgery. We continue our front treatment after surgery, still telling some sort of occlusion for her. And this is her pre-cephalometric view after surgery. This is her mandible after surgery. And this is her occlusion after surgery. So this is her profile and front view after surgery. She came like this, and she finished her treatment like this. Even her mom, she didn't recognize her at that. She was very pleased at that time, and she get married after the surgery after a while, after some treatment, and he used to thanks a lot, thanks us a lot more than one time. Our family called us more than one time. This is third case of or fourth case of this surgery in which we have class 3. So we have to have some sort of class 3 in this presentation. We used to use single distal articulators, but nowadays, or years ago, we changed from semi-adjustable to fully adjustable articulator. This one, this will give you accurate mock surgery and accurate transfer of the reading from the patient to the articulator. So now we have this. Here the patient pre-surgical, pre-orthodontic problem, pre-photos intraoral, in which you have class 3 spacing. The maxilla is completely engulfed by the mandible, and there is no occlusion. She has some sort of problem in eating, some sort of problem in everything. These are extraoral photo before surgery, in which we have concave profile here. So we carried out double jaw surgery for this patient, me and Professor together. Professor was the leader, and he did very nice work. We carry out some sort of level 1 for the maxilla. And whenever we have double jaw surgery, we're going to start with the fixed bone, which is the maxilla. And then we're going to carry out, we have to have some sort of intermediate waiver or intermediate spleen for the maxillary surgery. Then we are going to carry out the mandibular surgery, and we're going to fix it with the final waiver or final spleen for the case. So this is done in the mock surgery before this surgery. So we carry out some sort of level 1 for the maxilla, be advanced, and some sort of be bilateral secondary split or something for the mandible. This is her profile after surgery. So, new change. This is intraoral photo before surgery and before orthodontic treatment, and this is intraoral photo after orthodontic as well as orthodontic surgery. So huge change for this is profile for treatment, and this is profile after treatment. So my message for my colleagues, you have to avoid doing some sort of orthodontic treatment alone for asymmetric face, as well as for poor soft tissue morphology, more particularly for syndromic patients. And you have to avoid doing some sort of orthodontic treatment alone for long faces patients. So we have to determine this, what is long face, and when we are going to do surgery for the case, whenever we have the total facial height for the patient is more than 125 millimeters, so which we call it long face syndrome. You have to avoid doing some sort of orthodontic treatment alone for skeletal anterior open bites. Whenever you have skeletal anterior open bite, it is unstable if you're going to carry out just orthodontic treatment, or if you are going to carry out orthodontic treatment with one jaw surgery, still there is instability. So whenever you have skeletal anterior open bite, you have to carry out orthodontic treatment first. Then you are going to carry out double jaw surgery for this case, and then you have to carry out some sort of postoperative orthodontic again. Whenever we have moderate to severe case anterior-posterior discrepancy, in which you have the AP angle more than 9 or less than -3, like if we have +3 with an AMP angle -4, -5, -6, -9, -10, you have to carry surgery for this case. Whenever you have AMP angle like for +2 more than 10 degree, we have to carry out some sort of orthodontic surgery for the patient. Otherwise, we are going to move the teeth and we are going to leave the bone outside. And this is unstable, we are going to worsen the case more. So whenever you have or get more than 10 millimeters in non-growing patients, because if you have growing patient, we are going to do some sort of gross modification, as well as if we have severely profiling teeth and there is spacing, we are going to close the space and we are going to decrease the overjet. So whenever we have overjet more than 10 millimeter in non-growing patient, this is very important for us. You have to avoid doing some sort of orthodontic treatment around. Whenever we have long face, the facial height is more than 125 millimeters, you have to go for orthodontic surgery first, then orthodontic surgery, and then surgical orthodontics. So this is very important slide for us. Surgical orthodontics and stability, the hierarchy of the stability and predictability of the cases. We have very stable procedures like the maxilla. Whenever you're going to impact the maxilla, this is very stable. And nowadays with rigid fixation, this is very stable. Whenever you're going to advance the mandibular forward movement, this is stable. Whenever you're going to move the chin any direction, this is very stable. Stable, but not very stable. Maxilla forwards in class 3 more particularly. Maxilla any asymmetry in any direction, it will be stable, but not very stable. But nowadays with rigid fixation, this will help. With splits. So stable with rigid fixation only, maxilla up. Whenever we're going to back the maxilla, whenever we're going to taking the mandible forward, or whenever we're going to forward the maxilla with mandibular setback. Although mandibular setback is unstable, problematic sometimes, and problematic with more particularly with sleep apnea patients. So it will lead to some sort of respiratory problem by decreasing the nasal flow and the respiratory flow as well as the respiratory angle. So as we have mentioned earlier, avoiding taking the mandible back as possible as you can. So Maxilla forward with mandible backward with rigid fixation, it will be stable. Mandibular asymmetry with rigid fixation with plates, it will be stable. Problematic cases, if we are going to carry out the mandible retraction or mandibular back, whenever we're going to take the maxilla down, this is again is the muscle of mastication. Mastication, this which will lead to some sort of relapse. So try to avoid this if possible. Maxilla, widening the maxilla by surgery, problematic because the relapse is very high. So sometimes we have to go for some sort of overcorrection. I want to thank my professors who teach me a lot in surgery as well as orthodontic surgery. More particularly, we carried out a lot of surgical cases with Ahmed Suleiman, under general anesthesia as well as under local anesthesia for some sort of exposure. We carried a lot of cases together, and I was delighted for him. I'm delighted working with him. I'm going to thank him very well. My professor, Muhammad Abdulhab Hizi, we carried a lot of cases together, more particularly class 2 cases, premaxillary surgery, reduction genoplasty, sliding genoplasty, and we carried out a lot of cases. We used to do more cases together. And we shared everything together. It teach me a lot. Here's some sort of discussion inside the theater. My teacher, Professor Kamal Abbas, Professor Mursi, and Professor Michael Harris. He was the head department in King's College London, and this is a man who first course we carried out in ophthalmic surgery. I carried out with Professor Harris. He wrote a lot of books, and he shared a lot of chapters in a lot of books. Professor Harris. Harris is distinguished professor in surgery, surgery. Also, Professor Sam Levine, he teach me a lot, and we share a lot of discussion regarding surgical procedure as well as curator for surgical patient, and when we want to carry out some sort of interim curator, final curator, intermediate curator, when we want to carry out some sort of cases, we discussed a lot of together. Also, Professor Jerry Kane, we discussed a lot of cases with him, and more particularly, I discussed a lot of diagnosis with him, more in radiographs. We discussed a lot of how to diagnose the cases in radiographs in a proper way, and he shared me and teach me a lot of knowledge. This is the staff of the Royal College of Surgeons. Sometimes we used to discuss our cases even in the exam diet. I used to utilize every time with them to discuss my cases with them. Professor Omara, we used to discuss a lot of cases with him. I want to thank my professor in orthodontic department as well as discipline, Professor Haider Abdullah Hashim, Professor Adil Maged, my distinguished teacher, Professor Muhammad Abul Qasim. He teaches me undergraduate as well as in postgraduate. My mom, as well as my professor, Mal Abrafan, she teach me a lot. In the department, his former department in orthodontic in the Faculty of Dentistry, University of Rome. Professor Sheza, Dr. Abdelbagi, is distinguished in the surgery, and he teaches me a lot. Dr. Fayyad, my young brother, he helped me a lot. Uh, Here, some sort of discussion in the department. Me and Dr. Adel Maged, Dr. Bagi, this is our department staff. This is Professor Peter. Used to discuss a lot of cases with him during the exam dates. This is RCS staff. Also, we used to discuss a lot of them with them. Kara, Professor John Walsh, John Sheridan, Professor Albert, with Dr. Abbas, and Prof. We discuss a lot with Dr. Abbas in the anatomical side. Whenever we have some sort of anatomical problem in the cases, I used to discuss with Prof. Abbas. So thank for your attendance, for your the attention during this lecture. Thank you.
Thank you, Doctor, for this valuable information. Now, guys, we are opening the floor for questions, and we will begin with the questions submitted through the form. But if you have any questions, please write them in the in call message or raise your hand and turn on your mic.
العافية يا دكتور، تسلم الله يسعدك دكتور قمر.
الله يسلمك.
For the questions, I would like to thank Dr. Gamar regarding this very fruitful lecture, and really we are happy that you are refreshing our memory regarding the orthognathic surgical procedures, and it is very difficult actually part in either ortho department or surgical department, but with that challenge you lead the others regarding that. So we are thankful to you again, and really we are happy with this presentation. Thank you very much.
Thank you, Dr. Hashim Fayed Mohammed Said, the head department of orthodontic as well as the special orthopedics at Rabat University. Thank you for sharing your information.
Thank you, doctors. Okay, our first question is, which is the best age for the orthognathic surgery for both maxilla and mandible?
Very difficult question, but I will try to answer it. We used to carry out the surgery after 18 years old. Okay, so but sometimes, more particularly the American school, they have mentioned they can carry out the maxillary surgery a little bit earlier. From 16 years old, they can carry out the maxillary surgery. But we used to carry out the surgical procedure after 18 years old. Because nowadays we used to do some sort of maxillary advancement by which we call it reverse head gear from 8 years old up to 10, and we used to do some sort of expansion for the medulla before 15 years old, and we used to do some sort of expansion after 15 years old by which we call it MARPI nowadays. We start with temporary curve devices.
Okay, there's Dr. Bassam raised his hand. Go ahead, Dr. Bassam, please.
Dr. Bassam.
Dr. Bassam, do you hear us? Okay, I will read the second question and go back to Dr. Bassam again.
Bassam, he is one of
Salam alaikum.
you're welcome, Dr. Bassam. He is one of the professor of surgery.
Thank you, Salam, for this very nice presentation and large scale presentation. But in the back, موضوع الفيرانس osteotomy. The vertical osteotomy can be used just for asymmetry or mandibular setback. It cannot be used for mandibular advancement or severe advancement for we prefer to use sagittal septate osteotomy. Just this notice. Thank you so much, Dr. Kamal.
Thank you, Professor Bassam. And we used to discuss, Professor Bassam, he's one of the distinguished maxillary surgeons in Yemen. We used to discuss a lot of cases together. Thank you for your very nice information. Thank you a lot. I do agree with you. Doctor.
Okay, our second question is the best ortho surgical approach for orofacial clefts.
The best ortho approach for facial cleft, you have to
Yes.
start from 0 day. You have to join the team. We have to have team for cleft patient. You have to have center for cleft patient, and you have to join the team from the starting, from the day of birth. If there is some sort of intervention we're going to carry out to help, we are going to help. Even by very simple procedure, we're going to do some sort of steel strap to to facilitate the surgery for the surgery later on. We're going to take the prima della close to the heart ballot. And sometimes we can use some sort of obturator for the cases.
Okay, there's Dr. Rufaida. Please, Dr. Rufaida, open your mic and go ahead.
Assalamu alaikum. Thank you, Dr. Gamar, for very interesting and informative presentation. I would like to ask about the use of MARBI. Do you think using of MARBI and this assisted, implant reduce the need for surgically assisted rabbit maxilla expansion?
Thank you for your very nice question, assistant professor and senior consultant, Dr. Mufaida Sadiq, the Department of Orthodontic and Interventional Orthopedics at Milan University. Yes, nowadays we decreased going for surgical assisted bilateral expansion by using MARPI after thorough investigation, as well as doing some sort of CBCT for the patient, and knowing the depths of the palatal bone, in which we are going to put our temporary device inside the expansion appliance. So we used to do some sort of 4 temporary anchoring device, size 8, size 10, and sometimes we can use size 11 even. So for this, we used to do it without going for the theater. And this reducing the need for some sort of orthodontic surgery for narrow cases. Thank you, Dr. Wafid.
Thank you, Dr. Rufaida, for joining us today. Okay, our next question is how to identify cases needing combined surgical and orthodontic management, and how to plan treatment effectively between both fields.
We used to do some sort of joint clinic as a team. In our Faculty of Dentistry, University of Khartoum, we used to do the joint clinic every month on Wednesday. The first Wednesday in the month, we used to do our joint clinic with the surgical department and we used to share our knowledge together. We used to do some sort of presentation to the case, and we used to discuss the case together. So at that time, we are going to reach the final diagnosis for the patient together, and we're going to put the treatment plan together. And sometimes we need some sort of other discipline to share us, like the perio department as well as orthodontic department, and some sort of conservative treatment from the restorative department. And we used to discuss everything together. And sometimes we need to negotiate some issues with plastic surgeon as well as with ENT surgeon together. And this is the right way to sit together and as a team and to read the final diagnosis for the patient, and then we're going to start our treatment plan.
Okay. Um, study surgery or ortho to be an orthognathic surgeon.
You have to study both of them. If you are going to go, if you are going to go for surgery, you can just concentrate on orthodontic surgery cases to be like some sort of subspecialty for you. And then you are going to carry out the orthodontic surgery with other team. If you are going to go for ortho, you have to concentrate on orthodontic surgery cases during your training and after your training, and then you are going to make it easier for you to join the team of orthodontic surgery. So orthodontic surgery is a team. There is no specialty just which we call it orthodontic surgery. It's a teamwork. It's a teamwork. So we have to always we have to do it in a teamwork. Thank you for your question.
Okay. I hope he or she found his answer. Okay. Um, how, doctor, you management of unexpected events during surgical procedure?
For orthodontic surgery, we used to do our thorough investigation first, and we used to do some sort which we call it mock surgery before the surgical procedure, before going to the theater together. And then whenever we are going to go to theater, we are going to minimize the risk to the minimal levels. During my 12 years, past 12 years, experiencing orthodontic surgery with the surgical staff, we have no communication, alhamdulillah, till now. So whenever you are going to go for surgery, go for thorough investigation, proper investigation, all the analysis you have to carry it in a proper way. If you have any doubt, return back and discuss with the team. Never ever go to a theater without guaranteeing everything before doing theater. Whenever you are going to face during surgery, you have to have some sort of experience to deal with it. He's a professor in surgery, and alhamdulillah, there is no problem facing us till now.
Alhamdulillah. Um, okay. Yeah, doctor, it's look like your kids are joining us to support you.
Yes,
That's so sweet, حقيقة.
yeah, I used to ask them as a kids after doing surgical procedure for patient. I used to show them the photos for the patient before and after the surgery, and they used to mention to me this patient is older than this. So regarding the pre-orthodontic treatment, they show the patient like old, and after surgical treatment, they show because they are kids, they're going to give you the very well opinion without bias. So always I keep saying this is older than this, but I have to mention for them this is older than this. The after surgery is older than before surgery, but she looked more younger. Thank you, Dr. Aya, for sharing this idea.
Wallahi, we are really happy to have them here
Thank you.
for real and send them our love and regards.
Thank
Okay,
you. Thank you a lot.
to continue our questions, how to handle complex surgical cases? I think.
How to handle complex surgical problem like double jaw surgery with vertical problem. Whenever you have anterior posterior as well as vertical problem as well as transverse problem, this is some sort of complexity for you. So in this case, you have to sit down more than one time. You have to investigate a lot. You have to do some sort of X-rays, uh, cephalometric, OPG, CBCT. You have to do some sort of thorough reading for the X-ray and analysis, soft tissue analysis, hard tissue analysis, dental analysis, and you have to go for cost analysis, and you have to go for photo analysis. Then you are going to go for the team to discuss more than one time the case, and then you're going to settle the final diagnosis for the case, and then you have to carry out the full jaw surgery in this case to guarantee your stability. So whenever you have complexity, go for double jaw surgery, plus or minus chin surgery, genoplasty, sliding or reduction joint genoplasty.
Okay, let's go to the questions in the in call message. Um, Rian, okay. Samah asked that who is the first specialty to diagnose the need for surgical orthodontics?
There is no paper.
Um,
It's a teamwork. Yes, as orthodontist, we used to see the patient because he will come to the orthodontic clinic, but we have to do it in team. There is no one that is a first. We are team, and this is a success. Whenever we are going for team, we are going to succeed in this. Whenever we are going to do it alone, we are going to do some sort of complication for your case. So there is no one is first.
okay. Um, Mohammed Abdu, Dr. Mohammed Abdu said brief about the visual planning of orthognathic surgery.
You are a friend from the virtual from VTO. We used to do VTO for two surgical problem. Whenever we have anterior posterior as well as vertical problem, but whenever we are going to go for three-dimensional surgery, we are going to do some sort of which we call it surgical treatment objective treatment plan. So VSTO, systematic surgical treatment plan for the patient in three-dimensional. We are going to go for mock surgery. We are going to go for some sort of doing surgery in the model. We are going to create model for the patient with the CBCT X-ray. We are going to do it in the CAD/CAM system. And so whenever we have complex cases, we have to go for thorough analysis, more investigation, more X-rays like CBCT, but you don't need to go for every case for all this. If, for example, if I have premaxillary surgery only, I don't need all this. But if I want to go for double jaw surgery, plus or minus genioplasty, Lefort 1 bilateral sagittal split osteotomy, as well as a reduction or sliding genoplasty, and I have some sort of anterior problem, anterior posterior, as well as vertical, as well as transverse problem. I have to go for thorough analysis. So VTO, it will never be enough for you at that time. You have to go for further systematic analysis.
Okay. Dr. Rian Amir, every orthognathic surgery we need maxillofacial surgeon plus orthodontist at the theater. I think we repeat the question.
Absolutely, it's a teamwork. You need them. it is a tumor.
Okay, Dr. Samah Tawil said how many months are needed for recovery, or what is the process of recovery after an orthognathic surgery?
Me with Prof. Hizi we used to do the theater, the operation on, for example, say on Saturday, and he used to visit me and him. We used to visit the patient every now and then. So Saturday, Friday, Saturday, Sunday, Monday, he will write down for the patient to leave to leave the hospital. This according to Easy. He used to do so. So like 4 to 5 days, because already we have some sort of rigid fixation, surgical treatment very in a very proper way, and everything is settled. Whenever we're going to make sure everything is settled, Profizi used to do some sort of discharge for the patient.
Okay, Dr. Salah Taha asked, can Invisalign be effectively used in the pre and post orthodontic phases of orthognathic surgery, or are fixed appliance still preferred?
For my experience point of view, I like doing some sort of fixed braces for obstetric surgery because I need some sort of body tooth movement in a proper way. I have to have some sort of better and proper fixed appliance type from better company worldwide. I don't like doing some sort of Invisalign or some sort of clear bus orthodontics for surgical cases. So I heard some orthodontists doing so, but I don't like this way at all. In my experience, I used to do for every orthodontic surgery, I have to guarantee my work with fixed orthodontic appliance to guarantee my movement, all the type of movement with fixed appliance. But I have some sort of discussion for the Invisalign as well as which we call it clear bus orthodontics in general for all the type of movement. Sometimes I cannot carry out all the type of movement with clear bus orthodontics. I used to use this with mild to moderate cases. So I do agree using clear bus orthodontics for mild to moderate cases, but for severe cases I have to go for fixed orthodontic plans to guarantee my.
Okay, I think Dr. Bassam raised his hand. Dr. Bassam, please open your mic and go ahead.
Over some, very good.
دكتور
Okay, sorry,
محمد، شكرا
Bassam.
جزيلا، شكرا جزيلا لكم. بصراحة أحب أشكرك على ملاحظة قليل ما نرى أخصائي الأورثودنتيك أو الاستشاريين يتكلموا عليها. أنت في المحاضرة جبت إنه أفويد كاموفلاج، وجبت الحالات اللي نتجنب فيها الكاموفلاج. قليل من الناس اللي يتكلموا على هذا الشيء أو ينبهوا له، لأنه أنا في اليمن مثلا أكبر مشكلة بنعاني منها كجراحين وجه وفكين أو أورثوغناثيس هي مشكلة إيش؟ الكاموفلاج أو البري سيرجيكال تريتمنت. كثير من الناس بيشخصوا الحالات وبيعالجوها أورثودنتيك، يوصلوا إلى طريق مسدود، ما بيقدروا يتعاملوا مع الحالات خالص، بعدها بيبعثوها لنا. احنا بنعاني مشكلة كبيرة جدا جدا جدا. فاللي بيساعدنا فيها الفيرتشوال سيرجيكال بلاننج، فالموك سيرجري ما بتنفع بها كذا حالات. فأحب أن أشكرك، وهذا دليل إنك بتفهم في الأورثودنتيك وفي الجراحة، إنك فاهم عن إيش الجراحة، ولذلك نبهت لهذا الشيء. الكاموفلاج أكبر مشكلة نعاني منها إحنا كجراحين. شكرا دكتور.
شكرا Professor Bassam for your nice information, valuable information as well as your knowledge. Professor Bassam is distinguished mouth surgeon, and he used to do orthodontic surgery years ago. he faced a lot of problem in cases of camouflage. As I have mentioned before, don't go for camouflage if you have severe cases like A and B more than 10, A and B less than -3, like -4 and 5. Don't play with this case. Just go for orthognathic surgery. First start with ortho therapy, then go for surgery, and then go for post-operative orthodontic. So there is no way to play with cases like these cases, like a long pace, more than 125, overget more than 10 in non-growing patient. If we have skeletal anterior open bite, so cases like this, don't play with them. From the starting time, you have to tell the patient and the family, this case, it will go for necessary definitely, or otherwise we're going to worsen the case. So we're not going to do just orthodontic treatment, because orthodontic treatment just we carry out, we are going to carry out the orthodontic treatment for teeth as well as the alveolar bone round. For the basal bone, no. Thank you, Professor.
Thank you, Professor. And there is Fatima Hassan. She said, thank you, Professor, for your very useful information and cases. Our question is, she said, I have a patient with jump smile due to vertical maxillary axis hyperactive, and short upper lip, skeletal class 2, dental class 1 molar, and canine. Thus, we will need double jaw surgery or just liver one maxillary impaction is enough.
She have mentioned the anterior posterior problem, but she didn't mention the vertical as well as the transverse problem. If she had some sort of vertical problem like skeletal open bite or deep bite, in this case, definitely you are going to go for double jaw surgery. But if you have just only anterior posterior problem, like you have mentioned, only one jaw surgery sometimes it will help. It depends on your analysis, it depends on your investigation, it depends on the case profile, it depends on the X-rays. So if you have transverse problem, bilateral posterior skeletal crossbite or bilateral skeletal nerve maxilla. So it depends on the other analysis. But as you have mentioned, you have only anterior posterior problem. In this case, you can carry out sometimes you can carry out one jaw surgery. So it depends. You can send the case for us. We're going to do some sort of analysis. We're going to share you the information together.
Okay, Dr. Duha Maruf. She said, is it better to start growth modification early in a growing patient with a severe skeletal problem as class 3 with open bite, or to wait and proceed with surgery later?
Thank you, Dr. Duha Maruf. She is one of our distinguished candidates. Now she's doing her postgraduate in orthodontic as well as orthodontic surgery as well as special orthopedics. Thank you for a very nice question. Whenever you have very severe case, even class 3 or class 2, whatever, very severe cases, and we have analysis for this, you have to tell the patient from the starting time, even if the patient is 6 years old, you have to tell the family she will go for orthodontic surgery later on, whenever you have very severe case. But if you have mild to moderate cases, for example, class 3, and she came like 8 years old, we are going to carry out some sort of gross modification by reverse headgear. The most updated one is which we call it the real type. It was mass modular in previous years ago, and now they call it real type, which allows the patient to sleep well. So we are going to carry out some sort of advancement from 8 to 10 years for the maxilla. This problem is related to the maxilla. So in this case, we can modify the chips. If the case is related to the module, you can carry out some sort of risk modification by functional blindness for boys from 12 to 14 years, for girls from 11 to 13 years old. So it depends on the jaw, it depends on the case. Is it so very severe? You have to tell the patient, family from the starting time, she will go from unnecessary, she will go unnecessary later on.
Okay. Dr. Fatima Al-Hassan, um, you said normal overjet, deep bite, and normal transfers. I think she mentioned her question
Yes,
of vertical.
Dr. Fatima, if the normal vertical relationship, which we call it vertical relationship, and normal transverse relationship, so sometimes we can carry out some sort of window surgery in this case.
Okay, last but not least, we're uh, with Dr. Ala Al-Hadi. She said, what are the objectives for pre-orthognathic surgery orthodontics? It is for decompensation or for minimizing the severity of the case.
So actually for pre-surgical orthodontic, first of all, you have to do some sort of decompensation. This is very important, decompensation first. Then you have to go for alignment and leveling and harmony of the arches with their teeth. Then you have to do some sort of leveling and alignment for the teeth, and you have to reach the rigid wire, which is 1925 stainless steel. Whenever you are going to reach this wire, now you are ready for surgery. And you have to create a osteotomy line for the surgeon. Sometimes you need to go for some sort of pre-maxillary surgery, for example. You have to create a space between the roots, between the first premolar and second premolar, or sometimes between the first premolar and the canine. So you have to create this surgical line or surgical area for the surgeon to do his operation in this area. Otherwise, don't hurry up for the operation. So the objective first, you have to decompensate. This is very important because seeing the patient in the chair is not enough. 50% of the cases, you are going to see the 50% of the severity of the case, you are going to see it in the chair. But you have to go for analysis, more analysis, more particularly for X-rays, as well as photo, as well as model analysis. Then you're going to discover the other rest of the 50%. So you have to decompensate first. Then you have to do some sort of leveling and alignment. Then you have to create a space for the surgical line to do the surgery in this area by paralleling the root and taking the root away from this area. And you have to do to reach the rigid wire, which is 1925 stainless steel, and you have to do some sort of which we call it crimpable hook in the past, but nowadays we used to use temporary devices for the surgical treatment cases. So this is the objective for the before surgical treatment. Very important. And you have to create your splint for the surgery. You have to create your splint. If you have double user, you have to do some sort of two splint or two waiver, pre or intermediate waiver, and then as well as the final waiver for the surgery. Whenever you are going to prepare everything and to go for mock surgery first, this is objective of treatment. Before surgery. Thank you for a very nice question.
Okay, before I hand over the mic to my okay, if there are any questions, if there is any questions, please raise your hand or okay, Khalid, please open your mic and go ahead.
Whenever we have, as I have mentioned earlier, whenever we have cleft lip and palate, we have to go for cleft center. We have to go for the team, and we're going to put the treatment plan together. ENT surgeon, orthodontist, maxfac surgeon, pediatrician, pediatric endodontist, orthodontist, social worker. We have a lot. We have like a speech therapist, speech consultant. We have like 11. So the ENT surgeon, they have main role in treating the cleft patients. So we used to do it in team together.
Is it clear for you, Khalid?
So Khalid.
Okay.
Khalid. Yeah.
Okay. Sorry. Um, Um, Reem said, as a fourth year student, I have a question about multidisciplinary cases. If a patient needs orthodontics, orthognathic surgery, and dental implants, what is the best standard sequence to follow for these three procedures?
Very nice question. Whenever you have to go, whenever you have case like this, in which we are going to carry out some sort of orthodontic treatment as well as orthodontic surgery as well as implant, we have to start with orthodontic treatment first. Why for? Because we are going to do some sort of decompensation, leveling and alignment, and harmony of the faces, of the jaws together, and we have to create some sort of reed wire for the surgery, and we're going to create space for the surgical operation, and then we're going to do some sort of uh, occlusion harmony for the case. So first we have to start as orthodontist, and then we're going to go for surgery for the case, and then after doing the surgical procedure, in which you have proper occlusion, skeletally as well as dentally, then we are going to go for implant as a final procedure for this case, in which we are going to guarantee the spaces is well distributed for the implant. We're going to guarantee the occlusion as well, and the contact in harmony. Intermaximum, we have maximum intercussion between the upper and lower jaw as well as between the upper and lower teeth for this case. Then we're going to finish our case with very nice implant with implant uh, consultant or is implant operator. So first orthodontic, then orthodontic surgery, then post-operative orthodontic, then implant. Thank you for very nice question.
Thank you, Reem. Um, okay. Is there anyone have a question? Okay. Um, Before I hand over to my deputy, Isra, I just want to say we are truly grateful to all the attending doctors and professors, as well as Dr. Gamer, for his time and effort. Beyond that, we appreciate his support and interest in helping us produce beautiful and impactful work for everyone. We feel incredibly happy, grateful, and lucky, not just because Dr. Gamer, one of our university professors, but because there are educators with such a high level of dedication to science in our country. Thank you so much, Dr. Gamer. We really appreciate um, your joining us today.
Thank you, Dr. Aya Fatih. Thank you for your beauty and for your members in the dentistry student association. And thank you for my professors who teach me a lot. Thank you for my colleagues. Thank you for my young generation in the Faculty of Dentistry staff. And thank you for all the undergraduates at Faculty of Dentistry, University of Rome. And thank you for sharing our knowledge together, even professors with their candidates. They used to share knowledge together. I used to learn a lot from my candidates. I used to learn a lot from my students. And I used to learn a lot from my colleagues. So this is the right way. Wherever you are going to search for information, work for your colleagues, for your professors, for your students. I'm still learning from them. We want to continue learning from them. Thank you, our attendee from Yemen. Thank you for our attendee from Egypt, from Saudi Arabia, my colleagues in the Saudi Arabia, consultants and doctors, my colleagues from UK attending with us, our colleague from Ireland attending from us now. Thank you for all, and see you tomorrow with Professor Yusuf Osman Yusuf in the very rare case worldwide, double
Okay.
blow with
Uh,
Professor Yusuf Osman Yusuf tomorrow, inshallah. Thank you for today.
Saru, Isra, the mic with you now. Thank you, Dr. Gamer.
Thank you, Aya, for that. Hello, everyone. And with this, we have reached the end of our webinar. We would like to extend our deepest appreciation to Dr. Gamer Ahmed Suleiman for the outstanding presentation and sharing his valuable knowledge. It was truly an insightful and enriching session. Thank you, Dr. Gamer, for your time, and it's amazing session.
Thank you.
We would like to express our heartfelt thanks to all attendees from professors, doctors, graduates, and students. Your support and interaction made this webinar a great success. Also, I would like to thank our head Ilaf Mu'taz and her vice Razam Mahmoud for their support and contributions in producing this work in its current form. Thank you again for all, and we are excited to see you tomorrow in our last session with Dr. Yusuf Osman Yusuf in Real Surgical Insight. مع السلامة and good night.
Thank you. Thank you. Assalam.